floor is yours.
Okay. Bismillah ar-Rahman ar-Rahim. Assalamu alaikum and good afternoon, everyone. And thanks for the introduction. Thanks for the SSBMT for the invitation and for choosing this topic, which rarely get presented in most of the meetings. So that's a good choice. So it's a good choice for them, but it was a tough task for me because you've seen all of the very nice clinical trial and well done and phase 3 and all of the fancy data. When it comes to plasma cell leukemia, things are very different. So I had to, to collect all the pieces together, try to stitch them, and I was trying to get with the best conclusion that I can come out with. So apologize for that because there is a rarity of the data anyway. So I will start my presentation with one of my patients just to know how tough these patients are. So this is a 39-year-old gentleman. And always, tough cases, when do they come? They come on the weekend. So I remember that weekend when this patient came to me, and that was in 2020. So he came with WBC of 170, landed in ER, very cytopenic with single-digit platelets and hemoglobin of 5, and very sick, and and he had a renal impairment, so he was admitted to the ICU, and the blood film showed many circulating plasma cells that confirmed by flow they were expressing CD27, 38, 56, and 138. He had a very high kappa lambda ratio. And so it was, we could not, we did not need to do a bone marrow on him. We did all the testing on the peripheral blood. So the fish was actually triple hit. So he had all the bad markers, so 17p, 1q, and 1p deletion. So he was started on pulse dex with some response, and then we started him on the chemo. I remember even in the ICU, so he started on VRD PACE. He actually, after 2 cycles, he achieved a CR actually with disappearance of the plasma cells and even from the peripheral blood and the bone marrow. So it was an excellent response. We collected the stem cells with cyclo GCSF. In the meantime, we did HLA typing, and he had a full match sibling. So he went for auto transplant with melphalan 200, and then Rec Allo from his sister, 10 out of 10 match, and then we put him on double maintenance with lenalidomide, bortezomib. He developed actually grade 2 GVHD of the skin and the liver. So I was monitoring him, by annually with imaging and with the free light chains, because he's a free light chain secretor. And then he came with the right upper quadrant abdominal pain, ultrasound, and then CT scan showed a very large 10 by 10 centimeter mass in the liver. So, and surprisingly, that was not associated with any increase in the free light chain. So it was like so we did, I was, thinking that it could be another malignancy, but we took a biopsy and it actually confirmed plasma cell neoplasm. And the bone marrow was done and was negative. So it was completely an extramedullary disease with non-secretory. So we start him on ESA-KD. There was slight decrease in the size of the mass, but in the meantime, he developed leg swelling, and we did pan-CT, and it showed actually multiple deposits in the muscles of the thigh all over. A biopsy was taken, and it's actually also plasma cell neoplasm. So unfortunately, progressing, and clinically he got very ill right away with sepsis and renal failure, and unfortunately he passed away. This is just to show you how nightmare these cases are, and despite how much aggressive therapy this patient has received. So now, in terms of definition, so the plasma cell leukemia has evolved in terms of the definition. The older definition, I remember when I was in medical school and as a trainee in the beginning of of my training. So we learned that plasma cell leukemia is basically if the plasma cell represent more than 20% of the circulating WBCs, or an absolute number more than 2 million. But that has changed, and I will tell you why. So now, at this moment, the definition of plasma cell leukemia is more than or equal to 5%, and that's done by morphology. Would that be good enough? Now, I see some projections. So shall we use a lower threshold? And is morphology good enough to diagnose plasma cell leukemia? These are still an open questions. So the definition has changed based on the IMWG consensus. So basically, they looked at two big registry of myeloma patients, and they actually classify the patients based on the circulating plasma cells from 0, 1 to 4, 5 to 20, or more than 20. And what they found that there is actually a missing slide. Actually, yeah, so there was, there is actually a but basically what they found that the overall survival of the patients, once their plasma cells more than 5% goes badly low, and that defined that 5% should be a new threshold for definition of plasma cell leukemia. But the other question is 5% good enough? And is peripheral blood morphology is enough? Because, morphology is an operator dependent, and, you can have these plasma cells that, it looks like maybe atypical lymphocyte and can easily be missed. So in this analysis, looking at 185 patients with newly diagnosed myeloma, all of them, they underwent multicolor flow cytometry, and they found that 3/4 of these patients, they had a positive flow cytometry, but of a low level. When they looked at the patient where the flow cytometry was 2% to 20%, that represent close from 10% of these patients. And what they found that once we reach to a 2% by flow cytometry, the PFS goes low. So you can see a difference of 10 months in PFS just with any plasma cells of more than 2%. And when they looked at the prognosis of these patients with 2% and compare it to the older definition, which is more than 20%, you can see that these two lines are identical, which means that maybe we should go lower to that. And now the question that I would ask you, so where to draw the line? 20%, 5%, or 2%? Actually, is there a line to start with? And it's actually very important here, because as we are looking at the lymphoma patients, when we are looking at the LDH, do we have a line? I think the circulating plasma cells should be dealt with it as a continuous variable than categorical. Like, I cannot say that this patient has a 4% plasma cells, they are good. This patient is 5% plasma cell leukemia and a bad prognosis. I think it should be a continuous variable rather than categorical. And that actually represents that. You can see on this analysis that, patients with 2%, they did better than 3%, but the 3% did better than the 4%, meaning that the more plasma cells you have, the worse prognosis. So my message that I always tell it to my trainees, that do not forget to do a peripheral blood film on any newly diagnosed myeloma patients. It gets sometimes forgotten and can be easily get missed if you did not look for it. So now for plasma cell leukemia, so it classified into either primary or secondary. Primary meaning it's a newly diagnosed patients, never received any treatment. So this is more common. It represents about 3/4 of the plasma cell leukemia, where secondary, it happened in patients with previous diagnosis of myeloma, previously treated. Which one has, so primary is more common, Secondary has worse outcomes. Now, we see more secondary, and part of that because of the improvement of the treatment of myeloma. So we can see more of a natural history. So before, people with myeloma, they would die within 3 to 5 years. Now, 10 years plus, so we see more secondary plasma cell leukemia. So in general, it's represent 2 to 4% of all newly diagnosed myeloma patients, but I think it's underdiagnosed. Maybe part of it because we don't diagnose it right. Maybe we are not using the right technique. We are using depending on morphology rather than flow, and it can be missed sometimes. In general, these patients, they tend to be younger than their comparators, myeloma patients. So in terms of their presentation, usually it presents with aggressive presentation. So usually they came with more cytopenias, renal failure, and it tend to be more of light chain gammopathy or light chain component. And usually these patients would present with the true extramedullary disease, the non-osseous, and that's related to the lack of adhesion molecules like CD56, LFA1, LFA3, and VL5. Lytic bone disease is less common, but it is not completely not known. And in terms of the diagnostic workups, as you can tell, these patients, they have a higher burden, so they have a higher LDH, higher beta-2 hemoglobin, and heavier bone marrow infiltrations. And in terms of the immunophenotyping, they can have a little bit of differences. So they have B cell markers on their plasma cells like CD20, 27, and 28, and 45. And they tend to have, as we expect, more poor cytogenetic abnormalities like 17p, 1q, and 1p. And usually they have more than one abnormality. So this is actually summarized the different mutations that we see with these patients. So we see more TP53, more biallelic TP53, and more KRAS. So this table, just to summarize what I said, and you can see that these patients, they are younger, they have a higher disease burden, higher cytogenetic abnormalities, and more extramedullary disease. So historically, we know that these patients, they do poorly, and their median PFS is something around 5 months. And if we are talking about overall survival, it's just about 1.5 years. So they don't do well, and their prognosis is more worsen if they are more elder, so more than 60 years, if the platelet counts are less than 100, and if the circulating plasma cells in the peripheral blood is more than 20%. So in terms of prognosis, the Chinese group, they looked at large number of plasma cell patients, and they tried to look at all of the different variables, and they found that the most important prognostic markers are age, LDH, and 17p. They came with a normogram, and based on that normogram, you can classify the patient into either lower risk. Both they are poor risk, but they can be lower risk or higher risk, and you can see that in the diagram in terms of the difference of their survival. So in terms of therapy, these patients, they came sick, so you have to be prompt in your therapy. You have to be aggressive, and you have to tend for deeper responses, VGPR or better. Important point for my colleagues from any non-transplant center, if you have a patient like that and you want to treat it in your center, consult the transplant center earlier, because we have to start the workup for transplant earlier. We have to do the HLA typing earlier. So because we don't have time to waste, we have to immediately take these patients for transplant. So unfortunately, as I mentioned to you, in terms of randomized clinical trial, there is sparsity in the data. Most of the recommendations are coming either from small, perspective or retrospective data, or from registration and data analysis. So the EMN, they have presented their treatment paradigm for plasma cell leukemia recently. And so for patients with primary plasma cell leukemia who are transplant eligible, their recommendation is to go with 4 cycles of quadruplet therapy. followed by double transplant, so either tandem O2O2 or at O2LO if the patient has a suitable donor. Then you have to go with consolidation with 2 cycles, then maintenance. So in these patients, treatment holidays should not be done. So you have to treat until disease progression. If the patient is transplant ineligible and fit, also go with quadruplet continuous until disease progression. If they are non-fit, you can go with monoclonal antibody triplet, like either anti-CD38 with len or bortezomib or carfilzomib. So also earlier, this is, the treatment algorithm was published, and what I want to point here that chemotherapy can be added to these patients, especially if you want to induce a faster response to just overcome the leukemic phase. So addition, something like cyclophosphamide or liposomal doxorubicin. But the novel therapies should be incorporated in the management of these patients. Why is that? So this is actually one of the few prospective trials done on myeloma patients from the IFM group. So they looked at 40 patients with newly diagnosed primary plasma cell leukemia, and they were treated with alternation between PAD and VCD. And if the patient responded, and their response definition was stable disease with circulating plasma cells less than 1%, and they will go for auto transplant, first transplant, and then based on donor availability, if the patient has a suitable donor, they will go for REC-ALLO. If no available donor, they will go with second auto transplant followed by maintenance. Based on their analysis, outcomes was not the best. We know that these patients, they do very poorly. VGPR or better was only in about 20% of the patients. So, it's just to see how difficult these patients are. But the good thing that with the incorporation of the bortezomib, there was an improvement in the PFS if we want to compare it with the historical data. I showed you that what was known about plasma cell leukemia, PFS is around 5 months. In this trial, PFS was 15 months, with the median overall survival was 36 months, meaning that incorporating novel agent did something with these patients. So the second question that I have was, is carfilzomib better than bortezomib? So the HOVON, the EMN group, they tried to look at that in the EMN 12 HOVON 129 trial. So they had two different cohorts. The younger transplant-eligible patients, they received KRD times 4 cycles, followed by tandem transplant, O2O2 or O2 REC-ALLO if the patient has a suitable donor, followed by 2 cycles of consolidation with KRD, followed by KR maintenance until disease progression. If the patient is transplant ineligible, they would get KRD times 8, then KR maintenance until disease progression. So the outcomes was actually better than what we have seen in the IFM trial. So the VGPR or better was detected in about 3/4 of these patients, regardless if they are transplant eligible or transplant ineligible, and that was translated also in improvement in the PFS. So PFS around more than 15 months in the transplant eligible, and about 14 months in the transplant ineligible, with the overall survival around 3 years. What about incorporating chemotherapy? So lymphoma-like regimen, like VDD-based, VRD-based, KRD-based, hyper-CVAD. So to tell you the truth, no one can say that these regimens are better than the quadruplet. Why? Because most of the data in the literature is actually extrapolation from very old myeloma trial. So there is no direct comparison between quadruplet versus lymphoma-like protocols. And what's more than that, we've seen in the previous sessions all the data about the upfront therapy. So the Griffin, Perseus, in these patients, in these trial, plasma cell leukemia was excluded completely from this trial. So there is lots of uncertainty here. So to answer this question, maybe I would say, the Greek group, they looked at their registry, so 20 years of follow-up from 2001 till 2021, and they found 110 plasma cell leukemia, and they looked at what treatment that they have received. So 21 of the patients, they received DARA-based quadruplet, 16% received VRD, 52% they received bortezomib standard combination, and 11% they received conventional chemotherapy. And these are the treatment they have received, and we can see that in chemo in the standard bortezomib group, they included the VDD base and VCD. So basically they try to compare between the DARA-based quadruplet and patients who received either bortezomib standard therapy like VTD-based, VRD-based, or conventional chemotherapy. And they found that actually, and this is retrospective, so you have to understand the limitations for that the quadruplet associated with a better PFS, 25 months in comparison to 13 months, with a significant p-value. And in terms of the overall survival, quadruplet, the median PFS was not reached after 52 months of follow-up. That was resulted in a difference in the Kaplan-Meier curve, as you can see here.
3 minutes.
So the predictor for poor survival was 17p and platelet less than 100. So what are recommended induction in primary plasma cell leukemia? Based on that, I would suggest to you quadruplets with anti-CD3 VRD or KRD. Conventional chemotherapy can be incorporated into the first 1 or 2 cycles if rapid response needed and you want to get rid of the leukemic phase. Now, in terms of transplant, what to do, single, tandem, or allo? So the CIBMTR, they looked at their data over 7 years from 2008 and 2015. They're able to found this number of primary plasma cell leukemia. Around 300, they underwent auto-transplant. Around 71, they had allogenic transplant. The table in front of you is showing you their status at the time of the transplant and what induction that they have received. So you can see here in terms of the outcome, so the non-relapse mortality, meaning that the TRM, so the TRM in the allo, as we can expect, was more, but the relapse rate on the allo was better. So meaning that you even out, you are increasing the mortality by the allo, but maybe you are decreasing the relapse rate. So, but as a conclusion, you can see that the PFS was comparable between both and also the overall survival. The predictors for survival was good performance status. So if you want to take a patient for allo transplant, be selective in the good performance. So what to make out of this? Tandem transplant or allo transplant are close to each other in terms of outcomes in primary plasma cell leukemia. Allo transplant should be offered if there is a suitable donor, acceptable functional status, and should be provided early in the treatment course if it's going to be provided at all. So what's coming next? So the IFM now, they are doing this trial, the BCL2 trial, for newly diagnosed primary plasma cell leukemia. Patient will receive DARA VRD 4 cycles. First transplant, 2 DARA VRD, second transplant, then DARA VRD every 2 months, so meaning for 1 year, then maintenance. So that's still ongoing. What about incorporating the CAR T cell in the management of these patients? So there are 2 ongoing trials. One of them is a phase 2, so you can see here newly diagnosed myeloma, plasma cell leukemia. They would receive a VRD, CAR T, and then VR anti-disease progression. The other trial using a sandwich technique, so a VRD times 3, first CAR, auto transplant, second CAR, and then anti-disease progression. in terms of the relapse refractory setting. So it's tough. So basically, you use whatever you haven't used before, incorporate CAR T cell or bispecific for these patients. So it was noted that about 25 up to 75 of patients with primary plasma cell leukemia, they have 11-14. So there is some, some data about the use of venetoclax and management of these patients in term of small case series or case study, but it showed efficacy. So that could be an option. How to assess response? Same to as multiple myeloma, but you have to assess their blood film, and you have to do radiological assessment to look for response in their extramedullary disease. Supportive therapy, these patients, they are sick, they can present with TLS, so you have to give them adequate hydration, allopurinol, rasbericase if needed, adequate antimicrobial therapy, VTA prophylaxis, and in terms of bone-directed therapy, it's also recommended even if there is no bone disease. So in conclusion and recommendation, so plasma cell leukemia is a very aggressive form of plasma cell disorder associated with worse prognosis. Recommended therapy based on the current data and recommendations, induction with anti-CD38 VRD or KRD 4 cycles, first transplant, consolidation 2 cycles, same as induction, second transplant either O2 or allo if the patient is fit and has a suitable donor, maintenance with triplet or doublet until disease progression. Do not stop therapy for these patients. The patients are ill, initiate therapy as inpatient, especially in the first cycle. Consult the BMT center early, supportive therapy with blood product, antimicrobial, and growth factor support. Thank you so much.